Today's lecture will be on the ankle and the foot. Uh, and today what we'll be looking at is primarily the stance phase. So in this illustration, we'll primarily be looking at the 60% of the total movement of walking which occurs in the stance phase. One of the interesting aspects of the stance phase is this is where we usually see the majority of problems with walking mechanics that occur, and then they carry on into the swing phase. So we have different components. The first area is going to be with initial contact. We're going to have two things going on with initial contact. During initial contact, or when heel is contacting with the ground, we're going to see external rotation of the tibia, and we're also going to be seeing supination. So supination is a combination of three different movements that are going to occur with the foot and the ankle. Supination is going to involve plantar flexion of the ankle. We're going to see adduction, adduction of the talus, and also inversion of the forefoot. When we're looking into transferring weight, or what we classify as a loading response, the loading response is going to cause internal rotation, which will mean that we're bearing more weight on the inside of the tibial plateau. And it will also involve an aspect of pronation. And pronation means that we're going to see dorsiflexion at the ankle, abduction or abduction at the talus, and eversion of the forefoot. And then you can see that this area is fairly large. So we see a loading response, mid stance, and terminal stance. And this is just going to be the transfer of weight coming over into a standing position. The last position is going to be the pre-swing. And with the pre-swing, what we see is, again, external rotation of the tibia. And then again, supination, which is involving plantar flexion, adduction or adduction at the talus, and inversion at the forefoot. So this is a pretty complicated aspect that's occurring, and anything that's going wrong during the stance phase we'll see carry over into the swing phase. So one of the areas that we see in the stance phase is the dorsiflexion problems. So we have a key areas in the stance phase that can occur. We see overpronation, which again, pronation is dorsiflexion, abduction, and eversion. This causes a loading response, which causes shock forces to be sent up the kinetic chain. We see people who are staying pronated during the pre-swing phase. So here, they're still in that pronated phase, so they're carrying it over into the pre-swing phase. We also see individuals who are over-supinated. So we see individuals who are carrying the supination, which is plantar flexion of the ankle, adduction or adduction of the talus, and inversion of the forefoot. So these transition zones that we see here commonly occur where we see individuals who are stuck in these ankle and foot movements. We also see individuals who have changes in or around the hip region. So we see individuals who have an increased Q angle, which is the relationship between the anterior superior spine of the pelvis and the center of the patella. We see individuals who, when walking, they'll perform a hip hiking or hip hitching. So they'll lift the opposite hip. So in this example, their right hip is loaded, and then they'll lift and swing the foot around on the left side. We also see a common problem with ankle equinus, which means basically ankle stiffness. So this is going to limit ankle dorsiflexion, which we see dorsiflexion is involved in a big portion of pronation during 3 of the 5 phases of the stance phase. So when we're talking about a gait cycle, we have a prerequisite for a proper gait. We should see that the individual has a stability in stance during the 5 phases of the stance phase. When they are going from pre-swing to the swing phase, we should see that they have adequate foot clearance. We should see appropriate pre-positioning during the swing phase. So what that means is being able to position the limb into the contact or heel strike after the swing. There should be adequate step length. We should see an equal step length between left and right. And we should finally see an energy conservation. And energy conservation just simply means that the individual's visual range doesn't bounce, they don't move side to side during walking. So the energy conservation means that they're walking in a straight line without any compensations through either bouncing or swinging the leg side to side. The primary areas that we're going to center on is going to be the determinants of gait, which is going to directly affect the center of gravity. So we are going to see a pelvic rotation, and when we see a pelvic rotation, it should be within about 4 degrees of pelvic rotation. So when both feet are on the ground in a double support, we know that the limbs are essentially lengthened, and what we also know is this prevents the sudden drop of the center of gravity. So the right hip, if this is the left hip and then this is the right hip, we should only see the distance between the left and the right hip to be no greater than 4-degree difference between the left and the right. So as you stick one foot out, your left hip will rotate, and then as you step forward with the opposite, the other hip will rotate. Pelvic tilt, the pelvis on the swinging leg opposite to the weight bearing is usually lowered about 4 to 5 degrees, which then again, pertaining to the center of gravity, is going to lower the center of gravity during that mid-stance phase of the stance phase. We will see lateral pelvic motion, which means that the net center of gravity usually lies above the base of the support of the stance phase. And then we should see basically early knee flexion. At foot strike, you should have roughly about a 15-degree bend in the knee during a foot strike. And the easiest way to describe 15 degrees of foot strike would be having the leg in a full extended position and just releasing the knee into a slightly flexed position. That usually registers out to be 15 degrees. The other area that we see is the knee motion. So especially at mid-stance, we should see the knee extending as the ankle plantar flexes and the foot supinates to help restore the length of the leg. And this is important because it's going to diminish the fall of the pelvis. So again, it's directly centered around, or it is, this knee motion is essential for maintaining the center of gravity. And then these are what we consider the first 5 are going to be the determinants 1 through 5, which helps reduce displacements in the vertical plane. And then the last one is going to reduce the displacement on a horizontal plane. So when we're looking at 1 through 5, it's going to be about the vertical nature of the displacements that occur in the vertical plane. And number 6, the foot and the ankle joint, what we see at that area is we should basically see that at a heel strike, the ankle plantar flexion smooths the curve of the falling pelvis. So it's basically maintaining the position of the pelvis, and it's associated with controlling plantar flexion during the first part of the stance phase. And again, plantar flexion is extremely important when we look at plantar flexion as a determinant for supination. So in this slide, what we're going to be primarily focusing on is going to be, when we're looking at the stance phases, we're going to focus on all the muscular action that's occurring up to the pre-swing. And one of the most interesting aspects about this is we only see concentric activity occurring in the calf muscles and concentric activity occurring at the iliaps psoas. So a lot of the concentric or shortening aspects are going to come from the hip and the calf muscles for propulsion. And then we predominantly see the majority of activation is going to be lengthening. And this is usually because of the stride length. But we see eccentric in the gluteus maximus, medius, hamstring, quadricep, and pretibial during initial contact. And you can see in this chart how we maintain eccentric lengthening all the way through the terminal stance in the gluteus medius. And a lot of the muscles of the hamstrings and quadriceps during mid stance and terminal stance, once you're fully weight bearing, become inactive during the walking motion. So when we look at problems that arise, the primary one is going to be that we see stiffness in the ankle, and then we usually have some sort of a pronation problem. And pronation, again, means that we're going to see lack of dorsiflexion, lack of abduction or abduction, and eversion. We also see that transition at mid stance before pre-swing. They tend to stick in a pronated position, where we should actually see, going from mid stance to pre-swing, we should see the individual moving into the supination, which is plantar flexion, adduction, and inversion. So the difference between walking and running are very noticeable. Walking, you're always going to have one foot in contact with the ground. You'll be transferring your weight fully over to that foot. And running, there's a point during running where neither of the feet are in contact with the ground. So you're using more of that potential energy as you're running, whereas walking is definitely more controlled. So if you're going to fix someone's walking, it is going to be completely different if you're trying to change someone's running style. So the first aspect of the skeletal system that we should look at is going to be the area of mechanical advantage. And this is very similar to the setup of the patella, but we see the lateral and medial malleolus. These are going to provide mechanical muscles for, or mechanical advantage of muscles in performing eversion and inversion. And when we look at the muscles that are going to come down on the lateral side, so on the lateral side, we're going to have the peroneus brevis and the peroneus longus, which is going to come down along the length of the fibula and go under, fully underneath the foot to the opposite side and to the lateral side. And then on the medial side, we're going to see the mechanical advantage for the tibialis posterior. We call these the Tom, Dick, and Harry muscle, but the tibialis posterior. The tibialis posterior is important for inversion and plantar flexion. It also is a main stabilizer for the medial arch. And then we have the flexor digitorum longus, which wraps around the medial malleolus, and the flexor digitorum longus, its main job is to flex the distal phalanges of the lesser four toes, but it also supports the lateral longitudinal arch. So again, it plays a role in arch support. And finally, the flexor hallucis longus. This one is predominantly, when you look at hallucis, it means big toe. And this one is going to be flexing the big toe. And of course, the big toe would be the strongest of the 5 toes in the foot. And having that mechanical advantage allows for the flexor hallucis longus to produce more power. So here's another look at it. You can see now in this picture or illustration, what we see is the posterior tibialis is wrapping underneath the medial side here. And this is going to be helping to support the medial arch. The flexor digitorum longus, which is wrapping underneath the foot, this one is going to help support the longitudinal arch. And this picture over here is the flexor hallucis longus, and you can see how it is wrapping close to the medial malleolus and going underneath the foot. These illustrations are just a reminder where we see some particular connections. So the first area is going to be this prominent fifth metatarsal. We also want to point out the talus surface, or what we consider to be the subtalar joint. And when we were talking about the difference between pronation and supination, in this illustration I can draw it out here for you. So this would be your right foot. So during supination we would see the talus moving, adducting, and then during pronation we would see the talus abducting or moving away to the outside of the foot. So the tibiofibular joint is important. We usually see about 10 degrees of rotation during knee flexion and extension. So there is a bit of rotation that occurs. And the fibula is important because this is a primary spot where we see muscle attachments, such as peroneus brevis and longus. We know that the tibia is going to be more weight-bearing, and they're going to be connected by this interosseous membrane. This helps minimize the movement between the fibula and the tibia. And some of the key areas that we see with this interosseous membrane is in the inferior tibiofibular joint and the superior. In this area, what we see is that this interosseous membrane is actually holding or helping to hold these two areas of what we consider to be a joint between the fibula and the tibia. So the syndesmosis, as I just pointed out, that would be located up here, and this is the region of the ankle where we see predominantly where the syndesmosis can be most affected, where we see what we call a high ankle sprain, where the most severe would be affecting this area of the interosseous membrane. And then we also see the anterior and posterior tibiofibular ligaments. So we have one here, this is the anterior tibiofibular ligament, and then we have the posterior tibiofibular ligament. So in a high ankle sprain, what happens is these ligaments get stretched or strained, and it tries to pull the fibular joint away from the tibia, which then stretches out the interosseous membrane. This area would be what we consider to be the area for a high ankle sprain. A low ankle sprain is usually going to involve the peroneus brevis and longus tendons, so the muscle of the peroneus brevis and longus. One is going to be connecting to the fifth metatarsal, and the other one's going to be connecting underneath the foot. The longest is going to be connecting underneath the foot at the medial cuneiform. So we will look a lot at ranges of motion. Basically, we can see with ranges of motion in the ankle is the primary function of the ankle joint is for plantar flexion, producing propulsive forces. So 50 degrees of plantar flexion, but we should have somewhere between 15 to 20 degrees of dorsiflexion. So the greater range of dorsiflexion with knee flexed, this helps to reduce the gastrocnemius tension. And as mentioned earlier, we see that the fibula rotates between 30 to 35 degrees. And when we're looking at ranges of 3 to 5 degrees internally during plantar flexion, and when we're looking at the ranges of motion, we're looking at that 20 degrees from a non-loaded position. Moving on to the arches, when we look at the medial arch in this illustration, we can see that it is going to start in the back here at the calcaneus. It's going to run through the talus, and then it's going to make its way past the three cuneiforms, and eventually what we're going to see is the medial longitudinal arch is going to end at the metatarsal. The primary function of the medial arch, it's important for shock absorption. So at the end of walking, what we'll see is that you'll be bearing, or in a stance phase, you'll be bearing most of your weight on the ball of the big toe. The next one, the lateral longitudinal arch here, again starts at the calcaneus. It's going to go past the cuboid on the lateral surface and then goes to the fourth and fifth metatarsal. And this lateral arch is going to be important. Lateral longitudinal arch is going to be important for balance. And then the transverse arch is going to extend across the foot from the fifth all the way to the first metatarsal. And this assists the foot in adapting the foot to the ground. What that means is walking barefoot, if you would be walking on concrete versus grass versus rocks, this transverse arch would give feedback to the brain about adapting the foot to the ground structure that you're walking across. So with inversion, eversion, what we see is they're classified as a gliding joint. So we definitely have more movement with inversion, 20 to 30 degrees. And then with eversion, because of the deltoid ligament, we are definitely limited between 5 and 15 degrees. Again, when we're looking at ankle sprains, the most common ankle sprain is going to occur around where this peroneus brevis and longus come in. And the tendon that's affected the most is going to be the anterior portion, or what we consider the calcaneofibular ligament. So this ligament right here gets affected, and the anterior talofibular ligament, which is located on the outside here, so on the anterior surface of the fibula. And that's because they're in direct relationship to the peroneus brevis and longus tendons that's coming down. So usually we see this occurring with excessive inversion. The classic ankle sprain is the easiest way to remember this one. So with the deltoid ligament, this is going to only be affected if you put excessive forces during an eversion ligament or eversion movement. And when we see the deltoid ligament, we're going to have 5 separate ligaments. You're going to have the posterior tibial-talar ligament. And again, when we're looking at ligaments, it's going to attach the tibia and the talus. And then you're going to have the tibial calcaneal ligament, where it's connecting from the tibia to the calcaneus. And then moving one in, the tibular navicular, which is this one. And then the next one would be the anterior tibial-talar, this one. So when we're looking at these 4 ligaments, they make up a series of individual ligaments, but we group them together in what's called a deltoid ligament. Most of the time, if there's an excessive force in eversion, rather than rupturing the ligament, usually when you have a severe strain, you usually break off a portion of the medial malleolus. So this injury usually occurs also with some sort of a broken bone of the medial malleolus. And finally, when we're looking at acute shin splints, it's a very painful leg condition, usually associated with running activities. It can be associated with exercises or doing exercise with improper or worn out footwear or shoes. We also see people who are overpronated have problems with shin splints, and also people who are considered to be classified as flat feet or don't have a prominent arch. And this causes the flat feet or the lack of a prominent arch causes the arch of the foot to collapse when loaded, and it stretches the intrinsic muscles and tendons of the foot and the ankle. Most often, when we look at shin splint diagnosis, what we see is most often involved is going to be lack of strength or tightness that we see in the tibialis posterior. We see in the medial soleus and the anterior tibialis, which is usually weakened. But it can also go into the weakness in the extensor digitorum. So we know with this scenario, the easiest way to cure acute shin splints would be the Rice scenario, where you're using rest, ice, compression, and elevation. But for the chronic condition, what usually happens is it's going to require longer periods of rest. But we also know that if we are stretching the posterior compartment, like the soleus, the gastrocnemius, working on our Achilles tendon, tibialis posterior, any myofascial work in the posterior compartment. And then on the anterior compartment, if we're strengthening the dorsiflexors like the anterior tibialis, and we're working on just strengthening our dorsiflexors, this imbalance can be corrected to take out the acute and possibly the chronic side effects behind shin splints.